Good afternoon. My name is Michael Miedema. I'm the Director of Cardiovascular Prevention here at the Minneapolis Heart Institute. And in today's On the Pulse series, we're going to talk about these new weight loss medications. These are medications that have gotten a lot of attention recently. There's a lot in the news and a lot on social media. And so I think it's definitely worth talking about them and really sticking to what the science has shown us about them because they have shown pretty significant cardiovascular benefit. And so I think it's definitely worth discussing. And so we're going to phrase this as kind of 5 myths about obesity and these new weight loss medications. I hope you find it of some value. We'll have some time for question and answer after the slides. I don't have any disclosures in relation to this talk. And myth number 1 is that obesity is simply related to poor lifestyle behaviors. Obviously, what you eat and how active you are is has a significant impact on what your weight is. But the idea that that's the only thing that impacts your weight is definitely not the case. We know in the US and abroad, BMI, body mass index, so basically your height to weight ratio, has been increasing for the last 40 years. It's not been a subtle increase. It's a pretty significant increase. And it's increasing in men and in women. It's increasing in all different ethnicities. It's increasing in all different age groups. It's increasing in all different income brackets. Basically, across the board, we know that BMI has been going up, and it's been going up pretty substantially. And so the idea that this is just related to what people are eating and how active they are, that's definitely not the case. We have some recent data here from Dari Mozaffarian, who's one of the world's experts on nutrition. And he showed that in the last 20 years in the US, caloric intake is relatively stable. This yellow bar or orange line here is the amount of calories on average US citizens are taking in on a daily basis. And it's been pretty stable for 20 years. And yet BMI continues to increase. And we actually have pretty similar data for physical activity. We know over the first 20 years of this obesity issue, we did see an increase in caloric intake. We did see a decrease in physical activity. But now in the last 20 years, it's been relatively stable, yet BMI continues to increase. And so the question is, why is this? What is going on that we continue to gain weight? And one of the things that's come out of this is pretty complicated, so we won't dive into it too deeply, but I think it's important to understand, and that's the concept of these epigenetic changes. And so epigenetics is the idea that, when we're born, we have the genes that we have, and throughout our life, those genes don't change. However, which genes are turned off and which genes are turned on at a given period of our life can vary, and it varies based on our environment. And we have some pretty clear research over the last couple decades here that for whatever reason, certain chemicals in our foods, certain stressors that we have in life, various other things, there are certain things about the environment that we're currently in that the genes that boost metabolism seem to be turning off, and the genes that slow metabolism seem to be turning on. And so both those have a negative impact on metabolic rate, which then negatively impacts weight over time. And so again, the idea that this is just simply, people are getting lazy and they're getting hungrier, and that's where this obesity epidemic has come from, that's definitely not the case. We have environmental stimuli that are impacting this as well. And so the concept that as an approach to the obesity epidemic, we just simply need to, eat a little less and move a little more, that's not going to be an adequate response. We're going to need every tool that we have to try and fight this. And so that brings us to these new medications. And so when we talk about the new weight loss medications, we're talking about the GLP-1s. And so myth number 2 is that these GLP-1s are experimental. That's definitely not the case. GLP-1 is glucagon-like peptide, and that's a hormone in the gut. And when you activate that hormone, it has a multitude of effects across the body. But one of the main effects it has is that it slows gastric emptying. So it slows how your stomach processes food. And so when it slows down that gastric emptying, people need to eat less to feel full, and they need to eat less often to feel full. And so that leads to weight loss over time. But in addition to that, when weight goes down, we see significant reductions in blood pressure. We see decreases in triglycerides. We see decreases in LDL or bad cholesterol. We see increases in HDL or good cholesterol. We see decreases in total body inflammation. And so all of these things are positive effects that help to improve cardiovascular health. And these medications did not start out as weight loss medications. They started out being developed over 20 years ago as medications for diabetes. There are medications to reduce blood sugar, and they do effectively reduce blood sugar, but they also seem to impact cardiovascular health in a lot of other ways. And so we have semaglutide, which is Ozempic when it's used for diabetes. They're dosed a little bit differently when they're used for weight loss, and that formulary one is Wegovy. Liraglutide can come as Saxenda or Trulicity for diabetes, or Victoza when it's used for weight loss. And then the most recent one approved by the FDA is tirzepatide, which is Mounjaro when it's used for diabetes, and when it's dosed for weight loss, it's Zepbound. And so all these medications have come available relatively recently. But again, that for weight loss. For diabetes, they've been around for quite a while. And so we're not going to spend too much time going into trial data. I know that can be a little bit boring sometimes, but the important concept here is that for diabetes, these medications have been studied for over 2 decades. The SUSTAIN trial was published here in 2016, so almost a decade ago, and that simply looked at using semaglutide in people with cardiovascular risk or cardiovascular disease, as well as type 2 diabetes. So it was over 3,000 people. They followed them for a number of years, and the goal was to reduce their blood sugar, but more importantly, the goal was to look at cardiovascular outcomes, meaning do these medications actually prevent heart attack, prevent stroke, prevent cardiovascular death? Because at the end of the day, when we treat a risk factor, we're not trying to treat the risk factor, we're trying to improve cardiovascular health. And in this trial, it very clearly did that. They had about a 25% reduction in the cardiovascular outcomes that they were studying. That was mainly driven by a reduction in non-fatal heart attack and a reduction in non-fatal stroke. These medications seem to decrease the risk for atherosclerotic events, so events that are related to plaque buildup, and they seem to do that quite effectively. Now, more recently, this same medication was studied in people without diabetes. So a study as a weight loss medication to improve cardiovascular health. And that's this SELECT trial, which was just published just last year. And this is the one that got kind of the most attention. So it was 17,000 people. There were individuals who were age 45 or above that had a BMI of 27 or above, so just overweight or obese. So you didn't have to be morbidly obese to get into this trial at all. And they also had to have established cardiovascular disease. So these are people with a prior heart attack, people with a prior stroke, people with a prior stent or a prior bypass. They followed them for a number of years and again looked at that same outcome of non-fatal heart attack and non-fatal stroke and death from cardiovascular disease, same one as the previous trial. And what they saw was a 20% reduction in that endpoint of all those cardiovascular events. So significant reduction in the things that we try and avoid. So we saw improved cardiovascular health with use of these medications. And again, that seemed to be happening because of lower blood pressure, lower triglycerides, better good cholesterol, lower bad cholesterol, all those things that we see that improve health when people lose weight. Additionally, there was a 20% reduction or 19% reduction in all-cause mortality. And we typically don't see that with most of our preventive medications. You know, for cardiovascular disease, in terms of death from cardiovascular disease, there's arrhythmias and heart failure and a lot of things that aren't necessarily related to plaque buildup. And then for all-cause mortality, there's obviously lots of other things that can happen. And so in order to have a reduction in all-cause mortality, you just have to improve overall health by a fairly substantial margin in order to see that. And we saw that in this trial. So myth number 3 is that these GLP medications can frequently cause serious side effects. And the nice thing about it is that we have that trial data to look at. During those trials, they're obviously following for improved health over time. They're also keeping very close track of side effects to see if there's any sort of adverse events that are happening more often on the medication compared to the placebo injection. And so in that trial, when they looked at their outcomes in terms of side effects, it would look pretty promising. For serious adverse events, the number of people that reported a serious adverse event on the placebo group was 36%. So 1 in 3 people had something happen that was, required a hospital admission that was relatively serious over the number of years of the trial. And in the semaglutide group, it was 33%. So there's actually less serious adverse events in the semaglutide group compared to the placebo group, mainly because they had less cardiac issues and they had less surgeries and less procedures. These medications, when you lose weight, there's less orthopedic issues to deal with. So it seemed to improve outcomes on that front as well. When you look at just routine side effects, there was an increase on the medication compared to the placebo group. And I think that's important. In the trial, 8% on the placebo group had to stop it at some point. They thought there was something going on with the medication, but 16% had to stop it on the actual medication. And that was largely driven, almost entirely driven by an increase in gastrointestinal disorders. In gastrointestinal side effects. So they basically had an 8% increase in gastrointestinal side effects. And so because the medication slows gastric emptying, it can sometimes slow it too much. And when that happens, people have some abdominal pain, they can have some bloating, they can have some constipation or diarrhea, depending on the situation. And so this definitely can increase the risk for gastrointestinal side effects. And sometimes they're significant enough that they do have to stop the medication. So the risk, we could tell our patients that there's a less than 1 in 10 chance you might have to stop the medication because of issues with the medication. Quite often for the GI side effects that happen, if people don't go up on the dose, if they stay at the lower dose, they can go away over time. Sometimes we go back on the dose and that can make them go away. The majority of people that have these GI side effects can somehow get past them if we just kind of adjust the dose or wait a little bit. Most people will end up tolerating the medication, but on occasion we do have to stop it. And so our 4th myth is that the use of these will bankrupt our healthcare system. We've been hearing about that they're so expensive, and some of the payers have said, if we approve these for all patients, we're going to go bankrupt. And obviously, cost effectiveness is a significant concern. We don't want to use medications that are not cost effective. That being said, though, we have to think about the counter to this, and that's that the obesity epidemic is costing us a fortune. We know that on average, we're spending over $1.5 trillion a year because of obesity-related issues in this country, loss of work and health complications, all those different things that pop up. And so the World Obesity Atlas is projecting that by 2035, that'll be up to about 4 million. And they said 4 million is what the pandemic cost us in 2020. And so this is a substantial impact. And so any intervention we have that can decrease rates of obesity has the potential to be cost saving in the long run. And so these medications are expensive. We obviously have to work with insurance to try and get them approved. But to say that they're too costly, I don't think that's the case. It's simply risk versus benefits. And then finally, the final myth that kind of gets me the most worked up is that these GLP-1s are a replacement for a healthy lifestyle. And nothing could be further from the truth. A healthy diet and physical activity are the foundation of cardiovascular prevention, and they always will be. If we go back to the beginning of our research in cardiology, that's really the Framingham Heart Study, 1961. They really didn't know what caused heart disease at the time, and so they followed a group of people for about 6 years and looking at risk factors for heart disease. And the take home from that study is that very clearly heart disease and stroke are very clearly multifactorial. It's not just one thing that causes plaque to build up in your arteries. Your cholesterol matters, but so does your blood pressure and your blood sugars and what you eat and how active you are and your smoking history and stress and 5 other things. And so you can't just look at one risk factor and decide about somebody's level of risk. Similarly, you can't just choose one treatment option and think that's going to be effective. You want to choose as many treatment options as you can. And so we want people to eat as healthy as they can eat. We want people to be as active as they are going to be and active as they can be. And then the question is despite a healthy lifestyle, are you still at enough risk where we want to consider other preventive interventions? In some cases, that's a weight loss medication. So these clearly are not a replacement for a healthy lifestyle. They're in addition and they're complementary to a healthy lifestyle. And so I think we're going to have some question and answer, so I'll skip over these. I will say that at MHI, we've started a program to try and help get more people on these medications. We know that sometimes they require prior authorizations with insurance, which can take some time. They require appeals sometimes, and physicians don't always have a ton of time to do that. And so we set up a partnership with our Allina pharmacy team. And so we're trying to get more people on these medications if they're appropriate for the medication. And so it's patients 40 to 65 with a BMI above 30 and cardiovascular disease or a cardiovascular risk factor. And so if they have cardiovascular disease, if they've had a prior heart attack or prior stroke, we do recommend they consider the program. If they have a risk factor, then it's something they can consider. It's not necessarily mandatory by any means. And then we partner with our pharmacy team to have the pharmacist look into their eligibility for the medication, to go through the prior auth process, and to help the patient with the dosing. These medications have to start at a low dose and then slowly increase over time. And so the pharmacist contacts the patient and helps them get to the right dose at the right rate. And then they follow up on our prevention program to see how their progress and see how they're doing. We already have 200 patients enrolled in the program. We'll probably be publishing this data hopefully later this year. And we're just trying to get the medications to the right people. And so I think we consider these 5 myths kind of busted at this point. I think we can say pretty clearly, obesity is not simply related to a poor lifestyle. It's related to lifestyle, very importantly, but it's also genetics and environmental factors that play a role as well. They're not experimental. We have long-term quality data across a pretty wide range of demographics. These medications have been around for a while, and we have excellent safety data thus far. They don't come with a high risk of serious side effects. The rate of serious side effects seems to be quite rare. Not that it can happen. Occasionally, they probably can, but they seem to be quite rare. And the less serious side effects can happen on occasion, but quite often they can be managed by adjusting the dose or pausing the medication for a bit. They don't seem to be too costly from my perspective. We obviously want to factor in cost effectiveness. For some patients, they're too costly because they're not approved. But in the long run, there's definitely potential here for long-term cost savings if we can substantially reduce the rates of obesity. And then obviously, they're not a substitute for lifestyle behaviors. A healthy diet is the cornerstone of cardiovascular health. It always will be. Same thing for physical activity. These are not meant to replace those things. They're meant to complement those things. So I hope you found that helpful. I think we have some time for some Q&A here, and have a great day.
All right. Well, thank you, Dr. Miedema, for your time and expertise during today's On the Pulse session. A fantastic presentation as always. And hello, everyone. My name is John Rickert, the virtual event lead here at the Minneapolis Heart Institute Foundation. We'll just be jumping on here to help facilitate Q&A. So the questions that we have prepared today were all submitted prior via social media and other outlets. So thank you to our registrants who did submit a question, but please also feel free to add additional questions using the Q&A pod that's located at the bottom of your Zoom screen, as these questions may be discussed in a future On the Pulse session. So Dr. Miedema, the first question that we have from the audience is, how long should someone try dieting and exercising for weight loss before asking their physician about medications?
Yeah, again, that kind of gets to the last point we talked about. This is not a substitutional thing where it's yes or no. Am I going to do the weight loss medication, or am I going to do diet and exercise? Of course, we want you to do diet and exercise. We're going to start there for sure. The question is, are you at enough risk despite a healthy diet and despite physical activity that we need to consider something else on top of that? And whether that's a cholesterol medication or a blood pressure medication or a weight loss medication, the lifestyle part of it always comes first. And so typically, if you're on the same dietary pattern and exercise pattern for 3 to 6 months, that's kind of going to tell you what impact it's going to have. And so if things aren't going well, these medications aren't mandatory, but it's something we should at least consider.
So who is the best candidate for weight loss medications?
Yeah. These medications really right now are intended to reduce cardiovascular risk. And so if we're going to use them in patients to reduce risk, we should probably use them in the patients at the highest cardiovascular risk. And so this is not about cosmetic weight loss. That's not the goal here at all. This is about reducing heart attack and stroke and avoiding all those bad things that we want to avoid. And so the current approach would say, for people with diabetes, they've got obviously pretty clear indication there. For people with established cardiovascular disease, so I've had a heart attack, I've had a stroke, I want to avoid another one, that's obviously a pretty good group to consider treating. And then we see people with multiple risk factors who are still struggling with their weight, then it's definitely an option in that group as well.
Thank you for that. And on the flip side, who should not take these weight loss drugs? In particular, are there any heart conditions that would disqualify a patient from this type of medication? And this would include medication interaction.
Yeah. So they don't really interact with other medications for the most part. So that part is pretty safe. And we really don't have any cardiac conditions that are contraindication at this point. They're being studied in heart failure right now and look to be pretty promising there. And so, even in pretty sick individuals, they seem to be relatively safe. The one consideration, obviously, if you've got some sort of serious gastrointestinal disorder, right? So if you have really severe Crohn's, really severe ulcerative colitis, something like that, I'd be a little hesitant to start it in someone like that just because of the potential for GI complications, which might then worsen their underlying GI condition.
Yeah, absolutely. Thank you for that. So you briefly touched on insurance. Are these drugs covered by insurance to your knowledge?
Yeah. It's kind of a moving target. So I'm always vague with this answer on purpose because I'm likely wrong the next day. And so for diabetes, they're pretty routinely covered. So if you have diabetes, most patients can get on one of these medications, whether Medicare or private insurance. For weight loss, it's a little bit more dicey. For Medicare patients, they typically don't approve it at this point. They've got a lot more trial data coming, so I think they probably will in the future, maybe with some limitations. For private insurance, we get them approved relatively routinely, but not always. Insurance has changed fairly frequently, and so it really, again, if people are at high cardiovascular risk, we can quite often get it approved. If it's just, again, someone who's quite healthy but wants to lose a little bit of weight, then often they don't get approved.
Yeah, absolutely. So this attendee is asking, what happens when I go off weight loss drugs? Are these a lifelong type of medication?
Yeah, so this comes up pretty often where, if you start it, then you can never stop it. And I don't think that's the case at all. For diabetes, when we start it, we tend to keep it going because it really works well to control diabetes. For weight loss, it's a little more optional. I've had some patients that have lost the weight they've wanted to lose. When they've lost a lot of weight, they've been able to be more physically active and they've been able to completely come off the medication and do well. I've had some people that have gone back to the lowest dose and stay on that and do relatively well. I have some people that go back off the highest dose and immediately they start to gain some weight and they go back up to the high dose and stay on that. And so really, it's pretty variable from person to person. There's definitely no mandate you have to stay on it. There's not a lot of risk in stopping it other than that weight loss or the weight can recur again. You can gain weight off the medication. In one of the trials, they did stop the medication halfway through in half the group, and there was some weight gain, but it wasn't like they immediately went back to the weight they were before. It was relatively gradual over time. And so there's not a lot of risk in stopping and experimenting a little bit.
Yeah, that's impressive. And speaking of being impressive, so this question, an attendee asked, so Science Magazine dubbed the GLP-1 receptor agonist medications as the quote unquote 2023 breakthrough of the year. So similarly, a recent CBS News article claimed that these medications will change medicine. And I think most of our attendees can agree, this is a hot button issue. We've seen it all over the news and the media. So in your opinion, do you think these types of medications could change the world, or is that hyperbole?
Yeah, we get asked, are these a miracle cure, a miracle drug? There are no miracle drugs, but there are medications that have some that have better science than others, and this one has some really good science behind it. It works well, seems to be quite safe, it seems to be quite effective, and so historically, the medications we've had for weight loss haven't been that effective and potentially came with some cardiovascular risk, and so they weren't necessarily making people healthier over time. And so this is really the first time we have a medication that seems to improve cardiovascular health, and so I do think it's going to be one that we use quite frequently. I do think it's going to change the landscape of cardiovascular prevention. I would compare it similarly to the statin medications that really changed how we treat cholesterol in a pretty significant way. And so I do think they're going to have a significant impact.
Yeah, thank you for that. So in terms of the delivery system of these medications, is an injectable the only mechanism at this point, or
Yeah.
please speak to that?
Most of the current ones are a once weekly injection. There is an oral form that's being studied and is out and available right now. There's a couple that are daily injections. The majority ones that have the best kind of evidence behind them are weekly injections, though.
Yeah, thank you for that. So in terms of research, what pending or future research are you aware of surrounding these prescription weight loss drugs?
Yeah, there's several new ones that are being developed. And so in addition to blocking GLP-1, they're looking at if we block GLP-1 plus another hormone or two, that might have a better impact. And so those medications are undergoing active research. We'll actually be part of a research trial with one of those coming up here in the near future. And so, yeah, until we get the results, we obviously won't start using those yet, but there's potential that we'll have multiple different agents in the future, which hopefully would help within cost as well.
Excellent. Well, thank you so much for that. Those were the questions that we had submitted from the audience. Is there any final words that you'd like to say to our attendees before we sign off?
Yeah, if I think some people are sometimes hesitant to try new things and hesitant to start preventive medications in general. This isn't something that's a have to. It's not mandatory by any means, but if you have any concerns or have any thoughts about it, just talk to your primary care provider, talk to your preventive cardiologist, just at least have the discussion. Get some more information before you make the decision.
Absolutely. Well, that's all the time that we have for today, folks. A big thank you again to Dr. Miedema for presenting on this fantastic topic. And thank you to all of our attendees who joined us this afternoon. We appreciate your participation. Before we sign off, just wanted to mention that our next On the Pulse session is scheduled for Wednesday, May 15th, and that is going to feature Dr. Courtney Jordan Beckler, who's going to be presenting on maternal health matters, pregnancy cardio tips. So we're going to go ahead and add a link to the chat pod now, which you may use to register. We hope to see you there. Dr. Miedema, thank you so much. And thank you to everyone, and have a great rest of your day.
Thank you.